Okay, this is us now at part 6, 263, and we're still in joints, chapter 8. We're looking specifically at the knee joint, and I presented this one to you. Let's just review for a second here. We have the femur in the bent or flexed position, and the condyles are not, they're sort of leaning back away from the articular surfaces, the meniscus here. We have the anterior cruciate, the posterior cruciate. We have the lateral collateral, also known as the tibial collateral, not to be confused with the fibular collateral. Okay, they're calling it the fibular because it goes down here to the fibula. This one comes down to the tibia. Okay, so this is just regular, dense, regular connective tissue. This, again, the anterior cruciate is dense, regular connective tissue. But they are having their collagen flowing continuously, and the artist did a much better job here with this one to show the flow of collagen joining up with the meniscus. Okay, so the deal here is that when we're in this slight position of bending, okay, when does that happen? That happens when we've taken a stride and we've leapt forward. Maybe we're a football player or some type of athlete involved in contact sports, and we've planted the foot there, and we're about to push down the mass of our body and move forward, and then eventually we'll rock forward with this femur, and we'll be taking the next step. Now, of course, this could be interrupted by a large other athlete who comes this way and tries to tackle you. Now, this is the lateral aspect out here. This is the medial aspect. So they're coming at you from the side, and they're coming at you sometimes from slightly behind, because the person of interest here is usually quite fast, and the person who's defending is usually a little slower but quite a bit bigger. That's the nature of whether it's soccer or football or rugby or whatever it is that we're engaged in, is that the defenders are usually kind of big people, and that the person trying to score is a slightly smaller individual, and they move to this position. Now, on this next page, we're going to actually take a look here at, how shall I say, a little collision. Now, I'm pretty sure that after having just explained what I explained to you, that the artist who drew this is possibly Canadian. I'm not sure, but it's just a wild guess on my part, because that doesn't look like a linebacker or a defender in soccer. It looks like a hockey puck to me, and they label it as such, so I'm thinking Canadian. Okay, normally I don't see this kind of action with hockey pucks, but here in the Bay Area we do have Friday night football in high school, Saturday night college, and Sunday is when the professional leagues play. And for those of you that are at the hospital setting, especially in the ER, you'll get to see people of every caliber coming in with this particular wound. And the idea, again, is that we have a slightly bent knee. We have weight bearing. You can imagine that this person right here has planted their foot. And if there's a cleat involved, that means the foot's not going anywhere. And the main mass of the body is up here. And with pressure here, let's imagine a 250-pound linebacker rather than a hockey puck. And there's a lot of pressure here on the knee. And what's going to give, since the knee can't go this way, it doesn't have that sort of ability, is that the collateral ligament, tibial ligament, is going to break. And then that could also involve the meniscus because they're hooked up. And then, of course, the forces are actually also going to act upon the anterior cruciate and the anterior cruciate. So this is, by definition, the unhappy triad right here, is the tibial collateral ligament, the medial meniscus, and the anterior cruciate ligament. They're a little bit better represented in that previous picture right here. So, and that's why I named it up here, the unhappy triad, and tibial collateral, anterior cruciate, and medial meniscus. This is oftentimes, though, specially noted to be fibrocartilage, and the problem with cartilage in particular is that it's very difficult to repair it. It's very difficult for healing or reprogramming to take place. So this is a very unfortunate injury when it involves the meniscus. Okay, so that's that deal right there. Then we move on to the shoulder joint. The shoulder joint is the most commonly dislocated joint of the body. Some people are built in a very, how shall I say, narrow manner through the torso, and there's not a great deal of musculature or development at the shoulders. Oftentimes these are people, either very slender people of the male persuasion, a little bit more commonly females, because the connective tissues of the upper body don't form quite as intensely as those of the male. And so there's some problems with that, and I want to take a look at that. Again, we have this joint presentation that we saw before, and I want to take a look quickly at this particular view right here. And so here we have the glenoid fossa, where the head of the humerus is fitting, and then we have actually four muscles coming off of here. We have the I can say this. Let's take a look down here. We have the supraspinatus, the infraspinatus, teres minor, subscapularis. Supraspinatus is above, okay, and so it's coming from above the spine. The infraspinatus is coming over here from below the spine, and the two of them, along with the teres minor, are all going to a part of the humerus that is called the greater tubercle. There's one big muscle coming from this side over here called the subscapularis. That's the only one coming from the medial aspect. It's going to the lesser tuberosity. So we're holding on to the top of the humerus at the lesser and at the greater tuberosity. Now here's the problem. We're holding on pretty well, but should there be a blow from above, which should be protected really by the acromion process, right? So that's the acromion process over there. You should be able to put a package on your shoulder and carry it around, that sort of thing. But it's possible that you actually were on skis, going possibly faster than your body anatomy and how shall I say structure should probably be going, and you might have hit a tree, and you were leaning forward at that moment, and so the tree hit you in such a way, and maybe there was a burl right there or something that actually caught the top of your humerus and pushed it down and back. I've seen this happen also on cyclists out in the trails, so mountain bikers who, if they hit the wrong brake and the front brake gets locked up and they go over their handlebars, as long as they're on soil, it's not too bad a deal. But if they're in the parking lot, I have a story that goes with that that's probably too ribald for the moment. But nevertheless, I've seen somebody go slowly over their handlebars and fall straight down on their shoulder, and it dislocated the top of the humerus, actually went underneath the skin and back into the back. It was really quite a remarkable event, and that person had to go to the hospital and get their shoulder relocated in the correct place. But the deal is that this joint is weak in a downward position, in a downward direction. If it receives a blow from above and slightly anterior, it could actually dislocate downward. so that would be a bad thing. So here's what I need you to know about this joint, is that it's held together by the tendons of these 4 muscles. It's called the musculocutaneous, the musculotendinous cuff or rotator cuff. So please learn the sits muscles, supraspinatus, infraspinatus, teres minor, and subscapularis. Thank you.